The purpose of this video is to give you a solid introduction to abdominal MRI. When I went through residency, I found that there weren't really any concise resources that provided the most essential body MRI concepts, and although most residents got pretty comfortable with brain and MSK MRI, they were generally pretty weak at body MR. I found that early on, most trainees find the large number of sequences in abdominal MR confusing and don't understand the sequences themselves, how to use them, or how to approach an abdominal MRI. So the goal of this video is to fill that gap. We're going to briefly review the most essential basic MRI concepts and pulse sequences, only enough to gain an understanding of the common pulse sequences used in body imaging. Specifically, this is going to help us make sense of all of the acronyms that we see for each of the sequences, like SSFSC. We'll go through a typical abdominal MRI protocol and review a normal abdominal MRI. We'll also introduce basic tissue characterization and then illustrate these concepts by reviewing an abnormal abdominal MRI study. Future videos will review approaches to specific types of studies like pelvic MRI, prostate MRI, liver MRI, etc., which will include a discussion of normal and abnormal imaging appearances. Let's get started with some basic physics. This is going to be far from a comprehensive review. We understand that everyone has a different physics background, so we're going to assume no background. Even if you have a basic MRI physics background, I strongly suggest that you watch this video through. We will review only the most essential concepts. Recall that CT uses X-rays to create images of things that display their attenuation of those X-rays. If it attenuates X-rays more, like bone and metal, it's going to look brighter. And if it attenuates X-rays less, like gas in the lungs, it's going to look darker on the image. MRI is completely different and a little bit more complex. We could spend hours going over MRI physics, and even then, we'd still just be scratching the surface. But the primary purpose of this talk is to get you looking at body MRI as soon as possible. And, unfortunately, that still requires at least a superficial understanding of a few key MRI principles. Also, apologies to the MRI physics purists. This is intentionally oversimplified. I've included some links in the description to some great MRI resources if you're interested in having or taking a deeper dive. Simply put, the signal that we get and look at in clinical MRI comes from imaging hydrogen nuclei in water and in fat. These hydrogen nuclei, like in other subatomic particles, possess spin or spin-angular momentum. And this spin gives the nuclei a magnetic moment. To put it in a simpler way, think of each hydrogen nucleus behaving like a tiny bar magnet with a vector illustrating the magnetic moment. In the absence of an external magnetic field, all of these tiny bar magnets are pointed in all different directions. And if you look at the net magnetization vector of any particular tissue, it would be about 0. There would be no net magnetization vector in any direction. In an externally applied magnetic field, however, like an MRI machine, the tiny bar magnets tend to want to align with the magnetic field. So in a tissue, you end up with more magnetization in the direction of the magnet. The tissue has a net magnetization vector in the direction of the main magnetic field, as shown here. Let's look at an MRI machine. So a big part of this MRI machine acts essentially as a big magnetic field that is aligned down the bore of the magnet, and that's marked here as B0. The main magnetic field is down the bore of the magnet, which is also called the Z-axis or Z-axis. The strength of the magnetic field in clinical MRI these days is most commonly 1.5 or 3 Tesla. And this diagram shows these magnetic moments of the individual hydrogen molecules aligning with this field. Since the majority of them align, these add up to a net magnetization vector in the direction of the main magnetic field. When a magnetic moment is aligned in the field like we're showing here, this is considered a low energy state. Put more simply, the little bar magnets are naturally pulled in this direction along the z-axis or z-axis. It's easier for them to align with the field than to oppose it. The z-axis, again, is the longitudinal direction down the bore of the magnet. So, how do we translate this into MRI signal? Next, we apply something called a radio frequency pulse, or RF pulse, that is designed to tip the net magnetization away from the z-axis. The RF pulse is essentially a smaller, varying magnetic field applied at a specific frequency in a direction that is perpendicular to the main magnetic field. It's not really a radio wave, but instead it's electromagnetic energy with a frequency that is in the radio wave spectrum. A key point is that in order to tip the magnetization away from the z-axis, the RF pulse has to be at a frequency that matches the spin of what it's trying to tip down. For now, who cares about these details? What matters most is that the RF pulse tips the net magnetization away from the z-axis and into the xy plane. How much it tips away from the z-axis is called the flip angle. Here, for simplicity, let's say that this is 90 degrees for now, and again, with this 90-degree RF pulse, shown here with B1, the net magnetization is tipped into the xy plane, again, perpendicular to the z-axis that we described prior. The RF pulse does two things. One, it tips the net magnetization vector into the xy plane, as we just showed in this diagram. And two, it also makes most of the hydrogen nuclei start to precess in phase at a particular frequency. Think of precession as like a wobbling motion or spinning of an object like a top. The particular frequency that protons precess at is called the Larmor frequency, which is calculated by this Larmor equation. The equation says that the frequency here, F, is determined by the magnetic field, or B0 here. The stronger the magnetic field, the faster it precesses in sync after the RF pulse. The frequency also depends on the nucleus itself, which is reflected in this term here, gamma, which is the gyromagnetic ratio. If that's too much for now, just remember that the RF pulse does two things. It tips the magnetization into the xy plane from the z-axis and causes the protons to precess or wobble in sync in a particular or at a particular frequency. Another important point to realize is that we generally detect MRI signal in the xy plane with a coil, essentially a coil of wires. We know from basic physics that if we put any coil of wires in a varying magnetic field, this is going to create a measurable current in the coil. So in MRI, a net magnetization vector tilted into the xy plane like we've shown on this MRI diagram here, if the detector was down here, we have a net magnetization vector in the xy plane that is precessing in the xy plane. So it's pointing towards, then away, then towards the coil. And that varying magnetic field is going to create a current in the coil, and that's where we get the MRI signal. Let's look at that in another way. Instead of looking at it in the magnet or on an MRI diagram, we can look at it on this XYZ Cartesian system. So again, the magnetic field here is in the direction of the z-axis, which is down the bore of the magnet. The net magnetic moment is going to be in the direction of the main magnetic field, shown here as a blue arrow. An RF pulse is applied at the right frequency and at a particular flip angle, here 90 degrees for simplicity. And again, it's going to do two things. One, it's going to tilt the net magnetization vector into the xy plane. And two, the protons are going to precess in sync with each other, so the entire net magnetization vector is precessing in the xy plane, as illustrated here. And as mentioned earlier, we detect signal in the xy plane with a coil detector. The varying field in the xy plane towards, then away, then towards, and as it precesses, is going to create a varying magnetic field that's going to create a current in this coil, which is the MRI signal itself. So this is all great. We understand how we get MRI signal, but the key of any imaging is to differentiate tissues from each other so that we can anatomically look at organs and detect disease within them. So, how does MRI differentiate between tissues? So again, after the RF pulse, we've tipped our net magnetization into the xy plane. And as we showed earlier, the nuclei are also precessing like a top at a particular frequency in sync in that plane. This doesn't happen forever, and over time you start to lose your signal. Over time, through interactions with the surrounding environment, the net magnetization vector will relax back to the z-axis. Remember, the z-axis is the longitudinal axis, so this process is called longitudinal relaxation, also known as T1 relaxation. At any given point between the xy plane and the z-axis, there's going to be a net magnetization vector with a z-axis component or longitudinal component and a transverse component in the xy plane. What matters here is that depending on the tissue environment, the net magnetization will relax back into the z-axis at different rates. So at any given time, different tissues will have different amounts of detectable signal and can be differentiated based on this. If the vector hasn't recovered all the way back into the z-axis, it has a partial longitudinal component. If we apply another RF pulse when it has a partial component, the resultant net magnetization in the transverse plane will be equal to the amount of the z-axis component just prior to the RF pulse. This is important because, as we mentioned, we detect signal in the xy plane. So in order to detect differences in T1 relaxation, we need to allow them to relax at different rates in the z-axis and then apply an RF pulse and listen in the xy plane. A separate but related process is transverse relaxation, or T2 relaxation. Remember, we also mentioned that after an RF pulse, not only do we tip the net magnetization into the xy plane, but the hydrogen nuclei also start to precess in the xy plane in sync. In order to maintain signal in the xy plane or in the transverse plane, the precessing molecules have to 1. Remain in sync as they precess, and 2. Stay in the xy plane. So, over time, the transverse signal goes away, which is called transverse relaxation or T2 relaxation. In this diagram we have here, we have the z-axis pointing upwards, and that's again the magnetic field direction. And over here we have the xy plane that's flat. And early on we have a single line here that represents all of the precessing molecules in sync. And the red line here is the net magnetization vector that shows full signal at the beginning here. Over time, so this yellow line here represents time. Over time, the nuclei begin to lose their phase coherence, and they precess slightly out of phase and eventually lose signal in the XY plane. In other words, they relax in the transverse plane, transverse relaxation or T2 relaxation. This is based on interactions of the hydrogen nuclei with the molecular environment, and it's also referred to as the true T2 effect. A key point that might not be immediately apparent is that anything that causes T1 relaxation, as we showed here, and moves into the z-axis or moves the magnetization towards the z-axis, is always going to result in a concomitant loss of transverse magnetization. If all of the magnetization was in the z-axis, then the transverse component is going to be 0. In other words, any T1 relaxation is always going to cause or be accompanied by T2 relaxation. But there are other additional interactions that can also result in more T2 relaxation, as illustrated in this diagram down here where we lose phase in the XY plane. Remember, the precession has to remain in phase to keep transverse signal, so there is further loss of signal when they lose phase coherence. Knowing this, we can see that the T2 relaxation is always less than the T1 relaxation. In other words, T2 relaxation happens more quickly because, again, anything that causes T1 relaxation also causes T2 relaxation, plus loss of phase coherence causes T2 relaxation. So T2 times are always lower than T1 times. Again, don't lose sight of the main point here if none of that made sense. The main point here is that different tissue environments result in different relaxation rates, and therefore different tissues can give us different amounts of signal, and they look different on imaging. I should mention that T2 refers to true T2 effects due to energy transfers with the tissue environment. Again, the mechanisms aren't important, but what is important is the concept of T2 star. T2 star refers to observed transverse relaxation, which includes the effects of magnetic field inhomogeneities. Remember earlier we mentioned that hydrogen nuclei precess at a particular frequency, the Larmor frequency, that was directly proportional to the magnetic field strength. Any magnetic field inhomogeneity will result in some protons that experience higher field strengths and others with lower field strengths. So the ones that have higher field strengths precess faster than the other ones. If that happens, then, of course, you know that there will be a resultant loss in signal in the transverse plane very quickly because the transverse magnetization depends on precession remaining in sync. Local field inhomogeneity can be caused by things like metal, calcium, hemosiderin, all things that affect the magnetic field that hydrogen nuclei around these things experience. As a result, things around the metal, for example, will lose T2 signal very quickly and show up as very dark on these images. T2 star is always going to be shorter than true T2 because T2 star is just the T2 effect plus the effect of the magnetic field inhomogeneities. Before I go on, if you have no MRI background and are lost right now, that's okay. Just stick it out. We'll get to more clinically relevant things relatively shortly. If you take one thing away from the last few slides, it should be this. Any given tissue has a particular T1 relaxation time, namely how fast it recovers magnetization in the z-axis, and a T2 relaxation time, how long it takes for transverse signal to decay. And we can differentiate tissues based on this, which is the whole point of imaging. Now, in order to create MRI images, The MRI goes through a complex set of precisely timed manipulations, RF pulses, gradients, etc., called pulse sequences. We're going to go over some pulse sequences commonly used in abdominal imaging in the next section. But these pulse sequences are what are run to get you all of the images that you end up looking at on the workstation. The pulse sequences can result in images that are T1 weighted or T2 weighted, which describes which characteristics of the tissue we're trying to look at. Are we trying to differentiate tissues based on their T1 relaxation or their T2 relaxation? No sequence is purely T1 or T2 weighted, but a pulse sequence is designed to try to bring out the T1 or T2 characteristics of each of the tissues to differentiate them. And we'll briefly talk about how that happens in the next section. So let's start diving into what tissues are going to look like on these T1 and T2 weighted images that you're going to be looking at, using the concepts that we've learned of relaxation. Remember, in MRI, we're really only imaging hydrogen atoms in water and in fat, mostly water. So let's start by considering pure water and pure fat. Here we have water and fat hydrogen atoms. Yellow is fat and blue represents hydrogen and water. And they are aligned with the external magnetic field in the longitudinal or z-axis. We apply a 90-degree RF pulse, and the net magnetization vector is knocked down to the xy plane and precesses in sync in the xy plane. Water has a very long T1 relaxation time, so it likes to stay closer to the xy plane for a long period of time. Fat, on the other hand, has a short T1 relaxation time, so it recovers towards the z-axis pretty quickly. Fat now, after some time, has a much larger component than the water in the z-axis. The fat has recovered quite a bit more in the z-axis. So when we apply another RF pulse at this point again, the fat is going to have a lot more signal than the water. On pulse sequences that are T1 weighted, fat is going to be very bright, and water is going to look relatively dark. Similarly, it takes a long time for the T2 signal of water to decay, so you maintain your water signal on T2 images for a long time. On T2 weighted images, water looks very bright. Fat is a little more complex, so we won't talk about fat on T2 for now. What about all of the other tissues? What are they going to look like on MRI? So again, MRI is looking at hydrogen molecules in water and in fat. And we talked about pure water and pure fat on the last slide. We've also displayed these in the first two rows, so pure water and pure fat. So water is going to be T1 relatively dark and T2 pretty bright or very bright. Fat is going to be bright on T1 weighted images. It's more complex on T2 weighted images, but for fast spin echo or fast T2 weighted images, fat is going to look relatively bright. In other tissues in the body, like the liver or the pancreas or other tissues, we're not really dealing most of the time with pure water or pure fat. Instead, the hydrogen molecules in water and in fat, mostly water actually, are in an environment of other macromolecules. These macromolecules are going to affect the T1 and T2 relaxation times of the hydrogen molecules in the water in those tissues. So we're still imaging the water, for example, in the liver, but the T1 and T2 relaxation times are severely affected by the macromolecules that are in the liver. That's why in a normal liver, the T1 signal is relatively bright and the T2 signal is relatively dark. As an aside, most lesions that you're looking for, or a lot of lesions that you're looking for in the liver, are going to be T2 brighter than the T2 dark background liver, so they're going to stand out in comparison. Similarly, on T1 weighted images, most lesions are going to be relatively T1 dark compared to a brighter liver. But we'll talk about that more in the liver MRI video. Most pathology in general is going to have a high water content, so it's mostly going to be T1 darkish and T2 brighter. It's worth knowing a few commonly seen things that do not follow those signal characteristics. For example, the signal of blood products depends on the age of the blood products. But for now, and especially in body imaging, we're often looking for subacute blood, and it's often going to show up as T1 hyperintense or T1 bright. The T2 signal in blood is going to depend on when you're imaging it. This is similar to proteinaceous material and mucinous material. More proteinaceous and mucinous materials can be T1 bright and T2 darker, especially when the mucin becomes very dry or inspissated. Hemosiderin or chronic blood products are going to be dark on all sequences, so dark on T1 and dark on T2. And very fibrotic tissues are also going to be dark on T1 and T2 weighted images. There's not much water in densely packed fibrosis. Lastly, not on this diagram, but air and metal are going to look completely black on all sequences because there are no water or fat hydrogen nuclei in either. If this is confusing you, don't worry. After we get through this introductory stuff, we're going to pull up some MRIs and review all of this stuff again. For now, look at this image. This is a T2 weighted image through the upper liver. You see the CSF is bright here. That's almost like pure water. This is a T2 weighted image. Fat is bright here. The fluid in the stomach is bright. The liver is relatively dark, and we have a focal lesion here that is relatively bright. This happens to be a hemangioma. But notice how good MRI is at contrasting the background liver to the focal hepatic lesion. Let's move on to a brief primer on pulse sequences. Remember, pulse sequences are essentially precisely timed RF pulses or radio frequency pulses and gradients designed to generate MR signal that can be detected and turned into an image. The parameters of the pulse sequence are what will determine the tissue contrast. For example, whether they're more T1 or T2 weighted. A gradient echo pulse sequence is one of the simplest pulse sequences. A gradient echo pulse sequence starts with a single RF pulse. For example, this is a 90-degree RF pulse, but it can be lower. Magnetic field gradients are then applied, and we don't have time to go into details about gradients, but essentially gradients result in a varying magnetic field in space in a particular direction. Essentially a gradient in magnetic field in a direction, that's why they're called gradients. So you can have X gradients and Y gradients that vary in the X and Y planes respectively, for example. If the magnetic field strength is different in different positions, for example in the x-axis, then we know from our Larmor equation earlier that hydrogen atoms are going to spin at different frequencies in different locations. So with that, gradients allow us to make the RF pulses selective to a particular slice of tissue. It allows us to collect data from a very specific area and spatially localize the MRI signal, i.e., know where the MRI signal is coming from. This is beyond the scope of this talk, so we're not going to talk about gradients very much more, and we're really not going to include them in our diagrams and muddle up the picture. So we have this RF pulse, gradients do their thing, and then sometime later we have this echo, and this is a gradient echo. This is signal that we can sample. And then we do it again a little bit later with another RF pulse and then another echo down the road here. Okay, so now we have enough information here to define two key pulse sequence parameters. TE, or time to echo, and TR, or time to repetition, that are both measured in milliseconds. The TE is the echo time, or time to echo, which is defined as the time in milliseconds from the center of the RF pulse to the center of the echo. The TR is the repetition time, or time to repetition, also measured in milliseconds, defined as the length of time between corresponding consecutive points on repeating series. More simply put, from RF pulse to RF pulse. These parameters are important and are what determines tissue contrast. This is a very important point. You can have a gradient echo sequence that is more T1 weighted, T2 weighted, or somewhere in between. The type of pulse sequence doesn't determine the tissue contrast. The pulse sequence parameters, i.e. TE and TR, predominantly do. In a spin echo pulse sequence, there are two RF pulses at the beginning. We have a 90-degree RF pulse here, followed by an 180-degree RF pulse. Technically speaking, a spin echo can start with any two RF pulses, but most commonly we use a 90-degree RF pulse followed by a 180-degree RF pulse. And that's how we identify that this is a spin echo sequence. So the 90-degree RF pulse here tips the spins into the transverse plane and causes the nuclei to precess in sync in the XY plane, as we've mentioned multiple times. Over time, after this 90-degree RF pulse, there's going to be some longitudinal relaxation back towards the z-axis and transverse relaxation, or T2 relaxation. Also remember that there is transverse decay due to magnetic field inhomogeneities, what we introduced when we talked about T2 star. If certain nuclei experience a lower magnetic field, they're going to precess slower than the other protons, get out of phase, which is going to result in a loss of signal in the transverse plane. So, after all of those types of relaxation are occurring in the interim, we then apply a 180-degree pulse, which is also called a rephasing or refocusing pulse. The 180-degree pulse is halfway between the 90-degree pulse here and the echo, which is also known as the TE. So the 180-degree pulse happens at 1/2 of TE. The purpose of this 180-degree pulse is to bring the nuclei that precess out of phase due to magnetic field inhomogeneities back into phase. We then have our spin echo here, and the signal that we get here is not as sensitive to signal loss from magnetic field inhomogeneities as the gradient echo that we showed earlier. Again, we have the TE and TR, and these are the parameters that determine the tissue contrast. The way that this rephasing pulse is often explained is through an example of race cars in a race, or runners. If we have one car traveling faster, which will be 1, than the other, which is 2, the car that travels faster, like a hydrogen molecule that experiences a stronger magnetic field and therefore has a higher frequency, will get out of phase with the slower proton, or slower car. So if we let that play out for some period of time after a 90-degree RF pulse or the start of a race, they start to get out of phase due to the differences in frequencies or speeds if we're talking about cars. If we turn those cars around like that to face the start line again after a certain amount of time, and then we wait the exact same amount of time, the two cars will be back in phase at the start line. That is equivalent to the 180-degree pulse turning the spins backwards, and after the exact same amount of time, the spins will be back in phase. So the takeaway point here is that the spin echo sequences use this refocusing or rephasing pulse to reduce magnetic field inhomogeneities through this mechanism, And you can recognize a spin echo by having two RF pulses, usually a 90 and 180 degree pulse at the start. We mentioned earlier that the type of pulse sequence itself doesn't determine the tissue contrast. The type of contrast is mainly determined by the TE, time to echo, and TR, time to repetition. If you remember two things from all of this, remember this. One, shorter TRs will emphasize T1 effect, and longer TEs will emphasize the T2 effect. So why is that? Let's start with why short TRs, or short time to repetitions, emphasize T1 effect. Well, if we had shorter TRs, think about what happens when we repeat the pulse sequences. When we repeat the pulse sequences with a short TR, we do it so quickly that we don't let the magnetization completely recover into the z-axis before we start the next sequence. So different tissues have big differences in T1 signals, and that determines tissue contrast. So to illustrate that here, we've simplified our diagram into just showing the z-axis, and in blue we have water molecules, and in yellow we have fat molecules. If we apply a 90-degree RF pulse, the entire net magnetization vector is in the xy plane, and therefore there is nothing in the z-axis. After a very short period of T1 relaxation, these begin to relax in the longitudinal plane. The fat molecules, or hydrogen molecules in fat, have a much shorter T1 relaxation time, and so they relax towards the z-axis a lot quicker, and after a very short period of time have a bigger net magnetization vector in the z-axis. If we then applied an RF pulse at this time, the amount of signal that we would detect in water would be very low, and the amount of signal that we detected in fat would be very high, and that would be based on the differences in T1 relaxation differences between those tissues. So a shorter TI emphasizes that difference in the T1 relaxation effect. To illustrate that more, if we had waited even longer and had a long TR, we would have let the water and fat molecules completely relax into the z-axis, and then if we apply an RF pulse, there's no difference between the tissues, and so we've now completely gotten rid of any differences in T1 relaxation. So remember one thing here, again, short TRs emphasize the T1 effect for the reasons that we just mentioned. Also remember that longer TEs emphasize T2 effect. If the TE is extremely short, we're listening to the echo, we're detecting the echo right away, and we're not allowing much T2 decay to occur. If the TE is relatively long, we're allowing more T2 decay to occur before listening, and tissues will have different signals based on their T2 effects. If that doesn't make any sense, just remember what's on the screen. Short TR emphasizes T1, and long TE emphasizes the T2 effect, and you'll already be most of the way there. If you know those two things, then it makes sense that a T1 weighted sequence, or if you want to make a sequence that's T1 weighted, you're going to use short TRs to emphasize the T1 effect, as we mentioned, and you're going to use short TEs to get rid of or minimize any T2 effect. We want the images to be predominantly T1 weighted. T2 weighted images should use a long TR in order to minimize the T1 effect, and a long TE to maximize the T2 effect. Proton density, or PD, sequences aren't really used that much in routine body imaging, but they use a long TR to minimize T1 effect and a short TE to minimize T2 effect. And if you minimize both the T1 and T2 effect, you're just left with the density of protons. That's why it's called proton density. But again, we don't really use that much in routine body imaging. So let's apply these concepts to something clinically relevant. This is an MRCP, or magnetic resonance cholangiopancreatography image. It's a technique used to image the biliary and pancreatic ducts and help us look for things like stones, strictures, tumors, etc. We're really trying to get a good look at the ducts, and this is the CBD here, these are the intrahepatic ducts, and this is the pancreatic duct here. This is an example of a thick slab MRCP image, and we'll talk about how we acquire these in a little bit. But essentially, these are just very, very heavily T2 weighted images. Remember, water is very bright on T2 weighted images because water has a long T2 relaxation time. So if we emphasize T2 effects to a very, very high degree, we're going to get something like this, where signal is lost everywhere else, and only the water, or things like water, are maintaining their signal. MRCPs, therefore, use very long TEs. Remember, long TEs emphasize the T2 effect. So they use very long TEs to produce these images. Most other things lose the signal, and the water in the bile ducts and the pancreatic duct maintain their signal, and we get great images. Let's talk about fat saturation. So, fat is bright on images derived from T1 weighted images and fast T2 weighted sequences, as mentioned earlier. We often suppress the signal from fat for a few reasons, and we can do so in a few different ways. MRI is a little bit different than CT in how it displays signal intensities. In CT, we are displaying how much something attenuates X-rays. Things that attenuate X-rays more than water are going to look higher attenuation or brighter than water. With MRI, the structure with the highest signal on the image is assigned a value of 1, and everything else is imaged relative to that. So, if we want other bright things like gadolinium, for example, which is a contrast agent, to stand out, fat suppression is going to help make the gadolinium stand out better. Fat saturation also helps us detect bulk fat in things. So if something is bright on the T1 weighted image, like this subcutaneous fat here in the bottom right corner of the image, and it's dark on the fat saturated image, then we know it is truly bulk fat. And this can be clinically important. On the left here we have a T1 weighted image, again, bright subcutaneous fat, and here we have a T1 weighted fat sat image with dark subcutaneous fat. We also happen to have a large left adnexal mass in this young female patient, and it has a lot of T1 hyperintensity in it. On this image alone, we don't know exactly what this is, based on the signal at least. But if we look at the fat saturated image, we see that we lose signal here, or the bulk fat is saturated out. So this is a bulk fat containing ovarian or adnexal mass. This is a dermoid or mature teratoma of the ovary. What I want you to take away from this slide is the following. 1, fat saturation allows us to characterize tissues. We can figure out what has bulk fat in it, like the lesion that we just showed in the subcutaneous tissues. And 2, fat saturation makes the background dark, so other things that are T1 bright are going to stand out better. As I mentioned, there are a few ways to produce fat saturated images. For now, we're going to briefly touch on 2 of those methods. The first is called STIR, or short TI inversion recovery. STIR uses an inversion recovery pulse to null the fat. What is that? An inversion recovery pulse is an 180-degree inversion pulse before starting a conventional spin echo pulse sequence. So what does that do? Well, the initial 180-degree pulse flips magnetization into the negative Z direction. After a certain amount of time, based on their T1 relaxation time, they start to recover in the z-axis towards the positive z-axis. In a short amount of time, because fat has a very short T1 relaxation time, fat is going to cross through 0, and everything else is still going to have signal. If we apply the RF pulse at that exact time when fat is crossing 0, then we're going to get signal from everything else, and the fat signal is going to be suppressed as a result. This is how stir suppresses fat. There's also something called chemically selective fat suppression. I should introduce now that protons in fat actually precess or spin like a top slightly slower than protons in water. Remember, RF pulses only work if they are at a frequency that matches the Larmor frequency of the nuclei that it's trying to knock down. Chemically selective fat suppression first excites only the fat molecules with a very narrow RF pulse, and then it spoils or eliminates all signal from what was selected. Then the pulse sequence starts as usual and the fat signal is eliminated. Clinically, what are the advantages and disadvantages of these techniques? Well, if you want to remember anything, remember this. Stir fat suppression techniques often give us a more homogeneous suppression. They are less sensitive to magnetic field inhomogeneities, but we can't use stir with gadolinium. With chemically selective fat suppression techniques, we can in fact use them with gadolinium, but the fat suppression is often less homogeneous and it's more sensitive to inhomogeneity with things like metal. Okay, let's talk about diffusion-weighted imaging. Water molecules in most tissues in the body can freely move and diffuse in random directions, so-called Brownian motion. Simply put, in certain situations, this motion is restricted in the body and the water can't move freely. The motion or diffusion is restricted. Diffusion-weighted imaging images how much the diffusion of water is restricted in various tissues. This is very clinically important. If we look at this pulse sequence diagram here, this would create a DWI image. We have a 90-degree RF pulse here and a 180-degree RF pulse here, so this is a spin echo based sequence. And there are these very strong gradients labeled DG for diffusion gradients on either side of the 180-degree refocusing pulse. These gradients are, for all intents and purposes, equal and opposite in direction. In this pulse sequence diagram, we're going to get signal down here somewhere. And because we have to apply these big gradients, and these big gradients take time, the TE is going to be from this 90-degree RF pulse to where this signal is detected. So the TE is going to be long enough because of these gradients that take some time that there's going to be some level of T2 weighting effect to these DWI images. Remember, longer TE emphasizes TE effect, and we can't keep the TE so short because these gradients take time, so there's a long enough TE to have some level of T2 weighting on this diffusion weighted image. We're going to talk about that more in depth in a bit. But first, why do we apply these super strong gradients, and why does this produce images that are diffusion weighted? If we apply a 90-degree RF pulse, the nuclei start to precess in phase in the XY plane, as we've mentioned before. If we apply a very strong gradient or magnetic field that varies over space, which is a gradient, each of these molecules or nuclei here experiences a slightly different field strength based on where it is relative to this strong gradient. So we have a stronger magnetic field down here because of the gradient and a weaker magnetic field up here. Field strength is directly proportional to the precession frequency, the Larmor equation. These nuclei are all going to precess at slightly different frequencies, namely 3 is going to precess at a faster frequency, and 1 at a lower frequency. As a result, the ones that precess at a faster frequency or higher frequency are going to accumulate more phase. If we apply now a gradient in an equal and opposite direction, as we do here, and in the interval time between the gradients, these molecules or nuclei have not moved at all, aka their diffusion has been restricted, then they will be acted on by this opposite gradient and brought back into phase, and signal now is maintained for these molecules with restricted diffusion. However, if we go back, let's say that after this first gradient, again we have the strongest field down here and the weakest field up here. These all accumulate different phases as a result of a faster or higher frequency down here and a lower frequency of precession up here. So again, they accumulate different phases. Now, in the interval time before we apply the second equal opposite gradient, these molecules or nuclei happen to move. So they've moved from this position to this position. Now we have 3 at the top here, 1 at the bottom. They've diffused through Brownian motion, and their diffusion has not been restricted. Then when we apply the equal and opposite gradient, and they accumulate phase based on where they are, these are clearly going to remain out of phase, and when they're out of phase in the XY plane, they're not going to produce any signal, and the signal is lost from these tissues that are not restricted in their diffusion. So if that's confusing, don't worry. I just wanted to introduce the basic concept. What is more clinically important is what things that restrict diffusion look like on imaging. So things that have restricted diffusion are going to look bright on DWI images for the reasons that we just described. And on ADC maps, or apparent diffusion coefficient maps, they're going to look dark. ADC maps, or apparent diffusion coefficient maps, are calculated based on 2 DWI images at different diffusion strengths, or different B values, and we'll talk about that in a bit. The ADC maps display the diffusion coefficients themselves. So things with lower amount of diffusion, aka diffusion restriction, are going to have lower signals. They diffuse less. Something that restricts diffusion again is going to be bright on DWI and dark on ADC. Remember, we also mentioned that DWI images are spin echo based sequences that have some background T2 weighting. So if we just had this DWI image and we had this bright thing over here, for example, we don't know based on that image alone if it is due to diffusion restriction itself or due to background T2 effect itself. And that's why we need the ADC and need to look at both of these. If it's bright on the DWI and bright on the ADC, it's not true diffusion restriction. The bright signal on the DWI would have been due to T2 shine through effect. The last technical thing that I want to mention briefly about DWI is the concept of B value. The higher the B value, the stronger the diffusion effects. If you have a DWI sequence with a B value of 0, then there are no diffusion effects and you're essentially looking at a T2 weighted image. Higher B values mean more of a DWI effect and less of a T2 effect. This becomes important in things like prostate imaging, and this is a prostate cancer in these images up here. Prostate imaging requires B values of over 1400 to adequately assess for cancer. If that's too much, just remember again that things that like to restrict diffusion are bright on DWI and dark on ADC. DWI images are extremely clinically important. It's important to know what things restrict diffusion. The most common thing that we use DWI images for in body imaging is to detect cellular tissues, namely and most commonly tumors. DWI is invaluable in tumor detection and tumor staging, for example, in rectal cancer, cervical cancer, etc. And we'll talk about that in another video. Other things that restrict diffusion include abscesses and normal things like the spleen. When looking at an abdominal MRI, DWI images can be useful for a number of things, and we've mentioned the tumor detection, characterization, and staging. Also, they're helpful to detect lymph nodes. They pop out on DWI images, as well as multiple other things. I know that this has been dense so far, but we're almost out of the woods and ready to look at abdominal MRI. In comparison to MSK and brain MRI, abdominal MRI had initially been slower to develop. This is because most of the basic MRI pulse sequences that were initially done were very slow. They took a long time. This was not amenable to imaging in the abdomen, where cardiac, respiratory, and bowel motion results in pretty severe artifacts. The development of fast pulse sequences was necessary for the abdomen, and now that they exist, they've been used in abdominal MRI for quite some time. So we're going to review fast T1 weighted imaging, in and out of phase imaging, fast T2 weighted imaging, and MRCP. And these are the pulse sequences that essentially are the foundation of an abdominal MRI study. Fast T1 weighted imaging occurs through gradient echo-based sequences. As we mentioned before, gradient echo is pretty susceptible to magnetic field inhomogeneities, i.e., a loss of transverse magnetization due to dephasing of precessing protons. The longer we wait, the more that they are going to dephase. So an important point is that susceptibility artifacts are worse at higher TEs. If we wait longer for the echo, and we have longer echo times, there's going to be more dephasing due to magnetic field inhomogeneities. So we can minimize this by shortening echo times. And that's actually perfect for T1 weighted imaging, because remember, for T1 weighted imaging, we want to use short TRs to emphasize the T1 effect, and we want to use as short TEs as possible to decrease the T2 effect on imaging. The second thing that we can do that's important that makes things much faster here is we can use what are called partial flip angles, i.e., some value less than 90 degrees. Instead of every cycle having to wait for relaxation to occur all the way from the transverse plane and all the way back, we really only need to partially excite the protons. This allows for the next RF pulse to happen more quickly, and so you get a shorter TR, or shorter time to repetition. The shorter TR allows us to have a shorter overall acquisition time. Fast T1 weighted imaging is used in abdominal imaging for 2D and 3D T1 weighted images, or T1 weighted sequences. The 3D ones are often used for post-contrast dynamic imaging, for example, through the liver when we're characterizing tumors. These are some examples of some T1 gradient echo-based sequences that we use in abdominal imaging, and these are some examples of 3D versions of these sequences. And it's not important to memorize these names, but just recognize them. They're all going to be different based on the vendor of the MRI machine. For example, SPGR refers to a spoiled gradient echo type sequence. Vibe, Lava, and Thrive, again, depending on your vendor, you're going to know that you're looking at 3D T1 weighted images, and then you're going to see dynamic post-contrast images as well. Okay, let's move on to this important concept, in and out of phase images. This is very important in abdominal MRI. We mentioned earlier that protons in fat precess slightly slower than protons in water. And what that means is that while precessing in the XY plane, there are going to be points in time when the protons from fat and water are going to align or are in phase and additive. And there are going to be times when they oppose or are opposite in directions or are out of phase and subtract from one another. This is the principle of in and out of phase imaging. Out of phase imaging displays water signal minus fat signal, or the difference in the two. And in phase imaging displays water plus fat, or the additive signal of the two. Practically speaking, for imaging, this means that any voxel or volume pixel or little cube of tissue that has both water and fat hydrogen nuclei in it are going to look bright on the in-phase images and dark on the out-of-phase images. We perform these with a dual echo gradient echo. So it's just like the fast gradient echo that we showed you earlier, but we collect both of these echoes at the same time in the same acquisition. We acquire the out of phase and then the in phase. At 1.5 Tesla, these are the times that we generally acquire them at. So out of phase at about 2.25 milliseconds, and then in phase at 4.5 milliseconds. And again, because they're in the same acquisition, they're going to be perfectly registered to one another. And you'll see what that means when we open up an MRI relatively shortly. So let's look at some in-phase and out-of-phase images. So here on the left, we have an in-phase image and the TE is displayed. And here we have an out-of-phase image and the TE is displayed. And right away, with looking at these images, you can tell that this one here is the out-of-phase image and this one is the in-phase image. And the way that we tell is that the out-of-phase image has this dark line that surrounds these abdominal organs, for example, or any tissue here. So what is that dark line? That dark line is called the India ink artifact. And essentially, this happens because at the edge of any of these tissues, like the spleen, for example, here, there's an interface between a water-containing spleen and the bulk fat around it. So any voxel that's at the edge of this spleen here is going to contain water nuclei from the spleen and fat nuclei from just around it, and it's going to drop out. It's going to drop in signal on this out-of-phase image because the water and fat protons are going to cancel each other out in that particular voxel. So knowing that, if we're looking at the liver, for example, on these images, we see that the liver is relatively bright on the in-phase image, and on the out-of-phase image we lose signal. This is in keeping with a fatty liver. When you have a drop of signal in tissue on the out-of-phase image, we generally refer to that as containing intravoxel fat, tiny amounts of fat smaller than the size of each of the voxels or volume pixel. Each voxel has water and fat molecules within it. Notice that the fat in the subcutaneous tissues remains bright on both. That's because this is bulk fat. So on this image here, on the in-phase image, you're going to have water plus fat. So 0 water plus 1 fat is 1. And here we have the difference, and the difference between 1 and 0 is 1. So the signal is going to be the same. So the signal only drops on the out-of-phase image if you have both water and fat within a voxel. The other thing that I really want to emphasize is that the out-of-phased images are acquired first at an earlier TE. These are gradient echo based sequences. And as we mentioned earlier, gradient echo is susceptible to susceptibility artifacts. And these artifacts increase with increasing TEs. As with longer echo times, there's going to be more time for the precessing protons to dephase when you have magnetic field inhomogeneities. So at longer TEs, we're going to lose signal if you have susceptibility artifact. One thing that creates susceptibility is the presence of iron molecules. If someone had iron deposition in the liver, for example, which is going to happen with hemochromatosis or hemosiderosis, we're going to expect a lower signal on images with longer TEs or longer echo times. So we'd see a reverse of this picture of this fatty liver. Right? The image with longer TE, aka the in phase here, is going to actually be darker and the out of phase is going to be relatively brighter. That's why it's crucial that the out of phase is acquired first. If it was in reverse and the in phase was acquired first and with a shorter TE, and there was a drop in signal on the out of phase image, we wouldn't really know if that was due to fat because they're out of phase or due to iron because it has a longer TE. If you take away one thing from this slide, know this. You got to know how to detect intravoxel fat and iron/susceptibility artifact on the in and out of phase images. Namely, if it drops on the out of phase image, it's fat, and if it drops on the in phase image, then it's susceptibility artifact like iron. Now, moving on to fast T2 weighted imaging. In order to image with T2 weighted contrast, our TE is going to be longer. So we generally have to use spin echo based sequences in T2 body imaging to minimize susceptibility artifact. The problem with this is that conventional spin echo based sequences take a super long time, and that's not really feasible in body imaging because things are moving and people can only hold their breath for so long. In fast spin echo, during each repetition of the entire pulse sequence, there are multiple refocusing pulses. And these multiple refocusing pulses are used to create multiple echoes. These multiple echoes help us collect multiple phase encoding steps, or to simplify, multiple rows of data essentially are calculated or collected, in a single step. As a result, we can collect the data for the image in less repetitions and the scan happens much more quickly. This is what a fast spin echo sequence might look like. The number of refocusing pulses and therefore the number of echoes collected during each repetition is called the echo train length. So here it's 3. The longer the echo train length, the shorter the scan. A fast spin echo can be acquired in several ways. One common way in the body that is really good for reducing motion artifact is called a single shot fast spin echo. So an SS for single shot, FSC for fast spin echo. This is a fast spin echo sequence that collects an entire slice of data following a single RF pulse. So we have a single RF pulse and then multiple refocusing pulses and echo train lengths of over 100 after a single RF pulse, and we collect an entire slice of data. And so that's all that's meant by a single shot fast spin echo, or SSFSC, that you'll see in your abdominal MRI protocols. HASTE is essentially the same thing. HA stands for half Fourier transform. Again, it's just another way to make the signal or the sequence faster. And STE stands for single shot turbo spin echo. And turbo spin echo is essentially the same thing as fast spin echo, again, depending on the vendor. The main advantage of single shot fast spin echo sequences is that because you acquire an entire slice at once, each slice is very insensitive to motion and it's very fast. So you're not going to get much motion artifact on any individual slice. In body imaging, we see SSFSC scout scans, so they use them for scout images. Usually the initial T2 weighted imaging is performed using single shot techniques, and then certain types of MRCP can also be done this way as well. So since they're so fast, they can be used without the patient having to hold their breath, but since they're so quick, generally we acquire them by having the patient hold their breath and acquire all the slices in turn. If the patient's unable to hold their breath and they move around slightly while they're trying to hold their breath, you might notice that the image slices are kind of jumping, like they're not perfectly spaced. And that's kind of a hallmark of what you see when you're looking at single shot fast spin echo T2 weighted images, and we'll show you that on an MR in a bit. You can also have conventional fast spin echo images that can have better contrast and resolution if motion artifacts can be reduced. So a lot of protocols will also include a traditional fast spin echo. There are also certain artifacts that can avoid, but that's, again, beyond the scope of this introductory talk. On these fast T2 weighted fast spin echo sequences, remember, fat is going to look bright, and that has to do with the multiple 180-degree pulses. The mechanism is beyond this talk. We've mentioned this earlier, but the principle behind MRCP images is to use a very long echo time, or a long TE, to emphasize the T2 effect and in turn emphasize fluid signal. This can be done in different ways, commonly done in more than one way. First, with a single shot fast spin echo with thick slices, so thick slabs, and you can do them in different planes or different orientations. This is less susceptible to motion, but you get pretty thick slices, so other fluid-filled structures adjacent can kind of get in the way of our image. And then you can do a 3D MRCP, which is a fast spin echo based sequence that is a 3D sequence with very high spatial resolution. That can take longer to acquire, and again, we'll show you these images shortly when we go through a normal MRI. Other practical notes that I think are worth noting for abdominal MRI. One, what does flowing blood look like on these sequences without contrast? Well, for spin echo based sequences, most of the time we're doing fast spin echo based sequences that are T2 weighted. After a 90-degree RF pulse, most of the tissues are going to have signal in the transverse plane because we just applied an RF pulse. If we have flowing blood, on the other hand, that leaves the slice and is replaced by blood that has no MR signal in the transverse plane and it's all on the longitudinal plane, then there's going to be no signal, say, in the aorta. So this is a T2 weighted image, and you'll notice that the aorta with flowing blood is extremely dark. For T1 gradient echo based sequences with short TRs, blood entering the slices are going to look bright. Okay? And this is because blood entering the slices has all of the magnetization already in the z-axis or in the longitudinal plane. And as we mentioned, that's essentially as if they had a very fast T1 relaxation like fat. So essentially, inflow is going to look bright on these T1 gradient echo based sequences. And so you often see this in the aorta here, for example, at the superior aspect or the upper slices in the abdomen. And then in the lower slices in the abdomen towards the feet, you're going to see it in the IVC because venous blood obviously is going to flow from the legs and up towards the heart. If you were to scroll down in this image though, for example, this bright signal would decrease, and you also notice that none of these organs are enhanced. There's no contrast in the kidney. So these are in fact non-contrast images, but it's a common pitfall and common fake out. It looks like a contrast image because the aorta is bright, but it's not. This bright aorta is due to this inflow enhancement that is an artifact. We don't have time to get into an in-depth discussion of MR artifacts, but I really encourage you to read the appropriate essential topics. Again, there are links in the description, and I've also attached a link to a table that summarizes MRI artifacts and things you can do to try to fix them in the description. But common artifacts include ghosting from breathing, wraparound artifact or aliasing artifact, flow artifacts on SSFSC images, as well as susceptibility artifact that we described briefly as well. Okay, so we've made it past a whirlwind overview of some of the basic concepts, and we're ready to get into a practical reading of an abdominal MRI. So we're going to finish this video by going over first a typical MRI protocol. Then we're going to go through a normal abdominal MRI scan and show you these images and what they look like. And then we're going to go through an abnormal study. So first, a typical abdominal MRI protocol. So usually there are scout images that cover a greater amount of anatomy than the focus of the abdomen. So usually you have to look at these to make sure you're not missing anything that you might catch outside of the imaging field of view. You have then most sequences start, or most MRI protocols of the abdomen start with T2 weighted single shot fast spin echoes, usually in multiple planes. So for example, axial and coronal T2 weighted single shot fast spin echoes. Then usually there's at least one true T2 fast spin echo, and this is often done in an axial plane. We then perform MRCP images, so single shot fast spin echo thick slab MRCPs, as we mentioned earlier, and 3D respiratory gated thin slice MRCPs. So essentially these are those high resolution 3D MRCPs that we're going to show you. We also perform in and out of phase T1 gradient echo based sequences, and we showed you what those look like earlier. And then we have our 3D dynamic contrast enhanced images. So we have a T1 gradient echo 3D sequence, and it's usually fat saturated. We have a pre-contrast image, a dynamic arterial acquisition, so usually multiple arterial phase images to catch what the contrast is doing over time early on. We then have a portal venous phase acquisition and a delayed acquisition that are all post-contrast images. We then also acquire DWI and ADC images are calculated based on these. And so this isn't necessarily the order that they're acquired, but I've grouped them in order to better understand and think of all of these sequences and make them appear simpler. So we have our T2 weighted sequences, our single shots, and our conventionals. We have our MRCPs that are looking at the ducts. We have our in and out of phase T1 weighted image. We talked about that in detail. And then we have essentially our pre and post contrast 3D T1 weighted images and our diffusion weighted images that we also discussed in detail. So you should understand what this means now when you look at all of these sequences, and this should be more clear after our discussion so far. So now let's look at normal and abnormal abdominal MRI scans and see what the images look like. Okay, so this is an abdominal MRI study, and we're going to go through each of the sequences that we discussed in order. We'll skip the scout/localizer sequences and start with our single shot fast spin echoes. So this is a T2 weighted single shot fast spin echo coronal image. And we'll scroll through this and you see it's T2 weighted, so the CSF is bright, the fluid signal in the biliary system and the gallbladder is bright, the liver is relatively dark. Notice that the kidneys, spleen, adrenals, and pancreas here, you can follow the pancreas right there, are relatively dark on T2 weighted images. This is not fat saturated. Lesions in general, for most things, are going to be bright in comparison to these organs. So most of the time you're going to see things that are brighter in the pancreas or brighter in the liver or brighter in the kidney. There are exceptions, but that's what we're looking for. And these organs look pretty much normal on these. Notice that these are single shot images, so they're relatively insensitive to motion, relatively good images. But notice that when we scroll through it, it's not always perfectly placed. This is a pretty good example in a young patient who is cooperative, but sometimes in patients who can't hold their breath, they jump around a little bit more, but you can kind of tell it's a little different than what you're used to with a CT. There's some irregular jumps, for example. This here is the axial single shot fast spin echo, SSFSE or HASTE. So again, not fat saturated here. Large tissues like the liver, spleen. Liver is darker. Pancreas is relatively dark. Fluid signal is going to be relatively bright, so things like the gallbladder, the bile ducts stand out very well. You see there's no biliary duct dilatation. And you can see what normal kidneys look like. You also notice that there is very dark vasculature. Remember, we talked about why that was when we talked about what flowing blood looked like on these sequences. Next, we generally perform a T2 weighted image with fat saturation. This happened to be done as a single shot fast-spin echo as well. This was a haste image. And so you can see that because all the fat is so dark, the fluid signal stands out quite a bit more. So you're going to look for things like edema. So for example, if there was pancreatitis, you might see a lot of bright signal in the fat surrounding the pancreas that we wouldn't have seen on the earlier T2 weighted images. So the fat saturated T2 weighted images are really good for looking at fluid and specifically edema. Next, we talk about our MRCP images. And so as you can see, our MRCP images are just very heavily T2 weighted images. So things like the duodenum here that's filled with fluid is going to show up as bright. But what we're trying to focus on here is the biliary system. So this is the CBD that's quite beautifully imaged. We have our intrahepatic ducts here with our left hepatic ducts going to the left lobe here, and our right hepatic ducts on this side over here. So I'm anterior and to the left here, that's the left hepatic duct and left main bile duct. And on the right here we have our right duct, and our right anterior duct goes on a more oblique angle like that. You can see that's our right anterior duct. And our right posterior duct is often more horizontal. So in this plane. So notice if you follow that, that's our right posterior duct, and it inserts right here before it joins the confluence and then becomes the common duct, and then later the common bile duct after you have your cystic duct here. You can also see the pancreatic duct here. It's not seen as well because it's so small, but you can see that it's non-dilated here as well. We then have our in and out of phase images. So this is the T1 gradient echo out of phase image. So you can see it's the out of phase image. Again, you have this India ink artifact surrounding the organs due to the India ink artifact is a result of having voxels with water and fat molecules within, or nuclei within that cancel out. Notice the subcutaneous fat remains bright because that's bulk fat, not intravoxel fat. So this is the out of phase image acquired first. And this is the in-phase image acquired second with a longer TE. The liver is quite a bit brighter than it was on T2, so most things are going to look T1 dark in comparison to it. And notice that the pancreas is quite a bit bright as well. And so most things are going to look dark in relationship to the pancreas. We then have our fat-saturated pre-contrast T1 weighted image. Okay, so this is fat saturated, the fat is dark, and no contrast has been given yet. And this is a T1 weighted image. Okay, this is our gradient echo based sequence, and we're going to give gadolinium and then do multiple sequences. But notice how bright the pancreas is on T1 weighted images. So we talked about the liver, how it's bright, and how things are going to look dark in comparison. But the brightest organ on T1 weighted images in the abdomen is the pancreas, and look how beautifully it stands out here and how bright it is. When you have things like chronic pancreatitis, the entire pancreas can start to look a little bit darker, and that's an earlier finding in chronic pancreatitis. But the thing you're really looking for here is if it's very bright and you see a focal area or a focal lesion that's dark, you know that that's abnormal and you want to look at it closer on the other sequences. So the T1 weighted images are really good for looking at the pancreas and making sure it's normal. Then we have our post-contrast images, so we have our dynamic arterial phase images. And so here you can see that the contrast is now on board. We've given gadolinium. We can tell it's an arterial phase. We have typical tigroid appearance of the spleen. We know it's a good arterial phase because the arteries are well opacified. We have great enhancement of the pancreas. It's in a corticomedullary phase, the kidneys. And specifically, we have opacification of the portal vein that's early, and we have non-opacification of the hepatic veins. So early opacification of the portal vein with no opacification in the hepatic veins, that's a good phase to look for arterial enhancing lesions like hepatocellular carcinoma, for example. So for example, this is slightly later in this dynamic arterial enhanced image. This is slightly later than that even. You can tell the aorta is now less opacified and the portal venous system is becoming more opacified. This is still an arterial phase, in a dynamic arterial phase image. Even later in the arterial phase, so there are multiple dynamics here. And then we have our portal venous phase. So this is at 70 seconds. So our portal vein is now well opacified. We have opacification of the hepatic veins here. The spleen is more homogeneous. And we can see how our pancreas, our kidneys, and everything else looks. And at this point, the enhancement patterns are somewhat similar to what we're looking for on CT. We then have our 3-minute or delayed post-contrast image here, which is very important when we're characterizing certain things. Like if we had an abnormality, we want to see what it looks like on these delayed images. And we often perform a coronal post-contrast image as well. This sometimes covers a little bit lower down than and a little bit higher up than the axials. So I like to look at this to not only look at any abnormalities I'm trying to characterize, but also look at anything I might see in the pelvis, the bones especially for enhancing lesions, as well as any incidental findings in the lungs. Lastly, we have our diffusion weighted images. So you'll notice right off the bat on these DWI images that the spleen is bright. We mentioned earlier that the normal spleen restricts. So the splenic tissue signal on diffusion weighted imaging is a good marker for what is diffusion restricting. And so on DWI images, this is bright here. You'll notice that there are other bright things that are not actually truly restricting, like the gallbladder. So this is that T2 shine-through effect that we talked about. So the spleen is truly restricting. You'll also notice that the lymph nodes, as we mentioned earlier, pop out really nicely. So look at all these mesenteric lymph nodes here. They pop in and out of sight quite nicely. And so this is a good sequence to look at when you're looking for lymph nodes, as well as characterizing lesions and looking for focal lesions in the liver, for example. If we were to look at the ADC to prove that this is restricting, this is the ADC. We see that the spleen is dark on the ADC. It was bright on the diffusion weighted images, so this is truly restricting. Whereas if we look at the gallbladder was bright on DWI and bright on ADC. That's just T2 shine through that we talked about earlier. Okay, so that's it for a normal abdominal MRI. And we've gone through the sequences, shown you what the tissues generally look like on a normal MRI abdomen. Let's go through a quick case, and then we'll call it. Okay, so this is a quick case that does have abnormalities in it, and we won't go through everything, but we'll go through it briefly. These are the localizer images, so you can see that they cover more ground, and you can see more things. You can see that there's some cystic lesion here in the pelvis, for example, and already you can see that there's something that's quite big in the liver, so we'll get to that in a sec. So if we again start with our coronal SSFSCs, these are single shot, fast spin echoes, T2 weighted. Again, the liver is relatively dark, and abnormalities often stand out as being quite bright. So this is an abnormal lesion in the liver that's slightly T2 bright, or T2 hyperintense. There are other more subtle abnormalities here in the liver. This is a very slightly T2 hyperintense lesion, quite isointense to background liver, and there's a central area here that's a little bit T2 brighter. You'll notice again things like fluid are bright, the stomach, the CSF. We can look and see, we can see tiny cysts in the kidneys, for example. But it looks like most of the action is in the liver based on this overview. If we look at our axial fat sat images, we definitely see that this is quite hyperintense, this lesion in the liver. This is in segment 7 here, posteriorly. There are multiple other liver lesions here more anteriorly in segment 8, as well as down here in segment 5. We have this other lesion here that's quite isointense to background on T2 and has this central T2 hyperintense scar. We want to look at the in and out of phase images closely here. Whenever we're characterizing liver lesions especially, we want to look for intravoxel fat because that'll change our differential diagnosis. Here on the out-of-phase images, there's no background fatty liver. Of course, we compare to the in-phase and usually look at them side by side. So here on the in-phase images, we can see that this is slightly T1 hypointense posteriorly here, and these ones are slightly T1 hyperintense. This one is relatively T1 isointense. This is the one with that central scar. And none of them had fat. None of them looked darker on the out-of-phase images that we just looked at. If we look at our pre-contrast image, again, really nice pancreas. See how bright the pancreas is? Abnormalities would look dark in comparison. And we can see what our lesions look like here in the liver. Pre-contrast. And then we give contrast. And this is an arterial phase image. So the artery is quite well opacified, the portal vein is opacified, and the hepatic veins are just starting to opacify, so this is a little bit late. But you can see that this lesion down here demonstrates arterial enhancement around a non-enhancing central scar. These other lesions, there are multiple of them, but let's focus on this big one for now. This one that was quite T2 hyperintense also has some arterial enhancement. It's a little bit more heterogeneous, and there are non-enhancing areas as well. And there are multiple other lesions that are also arterial enhancing. Actually, I should mention that this is a EOVIS study, so we didn't give normal gadolinium contrast or purely extracellular gadolinium contrast that we're used to using in MRI. EOVIS or Primavist is a 50% extracellular contrast agent and 50% hepatobiliary agent that is excreted in the hepatobiliary system. So we look at these lesions on a 20-minute EOVIS scan or hepatobiliary phase, and you'll see that there is contrast in the biliary system because EOVIS or these hepatobiliary agents are excreted in the biliary systems. You'll also notice that some of these lesions, namely this lesion down here that was quite isointense, had a central T2 hyperintense scar, takes up EOVIS quite avidly, as well as this one up here. And all these other ones don't, especially this one posteriorly here that was quite T2 hyperintense, was heterogeneously enhancing on the arterial phase, and takes up no EOVIS. So this is a young female patient, and again, the purpose of this is not to show you how to characterize liver lesions. We'll talk about that later, but the purpose is to know what a normal MRI looks like and then show you how things stand out nicely compared to background on these various sequences. But these lesions here are predominantly mostly adenomas, especially this large one posteriorly. This lesion here, more inferiorly, is more confidently an FNH, or focal nodular hyperplasia. The taking up of EOVIS alone does not make that determination. Certain types of adenomas, like beta-catenin and inflammatory adenomas, can take up EOVIS, but the fact that this has relative isointensity to background, its pattern of arterial enhancement, its T2 hyperintense scar, as well as its marked retainment of EOVIS in the hepatobiliary phase are all in keeping with this being an FNH. However, this patient's main problem is that they have multifocal adenomas. Okay, this one is quite big and over 5 centimeters. So patients with adenomas are at risk for bleeding and later down the road can transform into malignancy. The rule of thumb is often that adenomas over 5 centimeters should be surgically removed if they can be. If they're confidently adenomas on imaging in a young female patient, for example, without other risk factors for hepatocellular carcinoma or HCC, then smaller adenomas that are less than 5 centimeters can be followed up. If the patient especially is on oral contraceptive pills, which is a risk factor for these, they can stop the OCP and follow it up shortly and see if they reduce in size. But again, that's well beyond the scope of this talk. I just wanted to show you an example of one abnormal MRI and how we can look at all these sequences to try to determine what we're looking at. We'll talk about the specifics later. Again, future videos are going to look at characterizing liver lesions. We'll have a liver MRI video. We'll also put out a pelvic MRI and a prostate MRI video as well to help you approach those studies. Okay, so that's it for now. I hope this was helpful. Thanks a lot.